some of you have put in the comments on the case management manual chapter 3, they would like to know a little more on diagnostic. So this is one of the important aspects. And today we would like to quickly review the recommendations and compare RDT and light microscopy. Maybe I mentioned something about PCR and molecular-based techniques. Tell you about recent changes in the market, and most important, how do we select a good RDT? What methods do we have in place? And so what are the quality assessment systems? And then we will have a quick video quiz about how to perform and interpret a RDT. So I'm asking you, what is this instrument? If you can put in the chat box, can you let me know? What is being used? Can you see on the photo, what is this little plastic instrument? Inverted cup. Dr. Salahuddin, thank you very much. This is the most precise way of taking blood from a finger prick, because it really has a very specific volume. And so if you can, when you select RDT, select what we call ancillary items. This is really the best blood collection device. Okay, thank you for this. Trying to move to the next. This is maybe something we all know, is basically everybody should get a test before being treated, and early diagnosis and should be done with either microscopy or a malaria rapid diagnostic test. And when we compare the two, these are very equivalent in terms of diagnostic performance. For instance, if we have a poor quality RDT and very poor quality microscopy, they can only detect a very high level of parasite densities. It's probably above 500 parasite per microliter. Now, if we have good RDTs and good quality microscopy, now the detection goes down to 50, 60 parasite per microliter. And if you go to PCR, we can get to 1, 2 with conventional PCR. We can even go 100 times below these levels if we use the highly sensitive PCR, high volume PCR. And we don't need this level of detection for malaria infection, because we have a lot of studies which have shown that for patients, when they come to health facilities, most of them, they have 200 parasites and above. So a good quality RDT or a good quality microscopist, they can detect this level of parasitemia. PCR at the moment is maybe good for molecular-based studies, like on transmission, which are done for research, for very specific needs, but not for clinical management of malaria. And when we look at the evidence, there has been a very thorough and very complete assessment of studies comparing microscopy and RDTs. And this is the analysis of 94 eligible studies, which were analyzed in a Cochrane review, and shows that the HRP2 test have a 95% sensitivity and around 95% specificity. if we use the PLDH test, the sensitivity is a little less, 93%, but the specificity goes up to 98%. But in both cases, this is very, very high. Can somebody tell me in the chat box why do we have a little better specificity with the PLDH-based test? Maybe not Dr. Salahuddin, he may know the reply, but is there somebody who wants to just venture? Why do we have a little better specificity with the PLDH-based test? We will go very much in detail in this in the next presentation, not today, but I want just to quickly assess if you knew it. Nobody? I don't see a reply. So let me move to the next. This is basically which are the roles for both RDTs and microscopy. I just want to show you that for certain functions, microscopy is much better. For instance, in a hospital, if I want to follow up some patients with severe malaria, microscopy is really the type of lab test I need to use. Or if I have somebody which has been already treated with malaria and is coming back and I have a suspicion maybe treatment failure, then I need to use again microscopy. So this is the two very specific functions for which we really have no doubt microscopy is better than RDTs. And when we look at the number of tests performed, this is for the whole of Africa. RDTs are probably around 80% of all tests, and in blue here you have the microscope. If we look at what percentage of people gets a test when they go to different facilities, a good amount when they go to the public health facilities, they get a test. This is all across Africa, so may not be fully applicable to your countries, but these are average figures. But if we go to community health workers, also they're pretty high, quite good. If you go to some formal private healthcare facility, like a private hospital, a private clinic, they also are quite good. I would say similar to public sector. But if I go to other health facilities in the private sector, including like pharmacies or accredited stores, very few people have getting a test. In the formal private sector is extremely rare. So this is still a big problem. A lot of people which goes in the private sector, they get anti-malaria without any form of testing. And this is what is happening in terms of big orders. These are for the whole of, let's say, the latest figures of sales. These are the P-falciparum only test sold in Africa, and these are the combo tests sold in Africa. This is from the manufacturer selling data. This is outside Africa. So you see that the largest consumption and use of the test, malaria RDTs, is in African countries. And these are the figures of how much the malaria programs report back to WHO that they are distributing. So this is manufacturer data, and this is the program data, and little less in terms of distribution, but very similar. Most of the tests are for detecting falciparum, especially in Africa. And this is just a very quick summary of what are the major determinants of quality, and showing a comparison between microscopy and RDTs. So when we look at which factors are affecting the performance of the test for the RDTs is really the product selection is most important compared to any other parameters like how it has been stored and maintained in health facilities, the training capacity of health workers. These are really important always, but not as important in terms of which test is it purchased and distributed and becomes available. Now look at microscopy. This is just to give you the difference. In microscopy, the major determinant is the performance of the test by the health workers. And it's not so much the type of microscope or the type of blood slides or KIMSA, etc., which is being purchased. It's really the competence and the performance of the microscopist. And this will be also what we will discuss in the next presentation. So let us go a little bit on the RDTs more in detail. This is the buffer solution. This is a typical cassette. This is another type of blood collection device. This is, of course, you know, the lancet and the alcohol swab. And WHO has a system to do periodic evaluation of the performance of this test. And so far, up to 2018, WHO has done 8 rounds of assessment and more than 327 RDTs have been assessed, and this as unique products. And this is interesting because when you go into a clinical outpatient setting and you do test on any of these patients, could be a child or an adult, different age groups, they will have different parasite densities and also different level of the parasite antigens, which this test is detecting. And when you need to compare different tests, first you cannot do on the same patients multiple finger pricks to assess at the same time many different RDTs. So most of the evaluation is done in the lab, is using some samples which are all characterized. They are calibrated to have a certain parasite density, and there is a high and a low parasite density, and also very well characterized antigen concentration. And the system is quite elaborate. I will not enter into the detail, but for each test, there are assessment is done in 2 lots, and from each lot, 2 different tests are evaluated, and these are read in a different way independently by 2 lab technicians. And each process is then repeated multiple times on different samples of Plasmodium falciparum. In case of falciparum is around 100 different samples. In case of Vivax is around 40. And for samples to be called detected, we have all 4 readings needs to be positive at the same time. So even if in this different examination, there are many positive cases, and we could have a positivity rate which is quite high, when we evaluate the RDTs, we look at only results in which for 1 samples, all tests as a result positive. So in this case, and this is what we call panel detection score, it is only 33%. Why I'm telling you all this? It's to give you some understanding what is behind this complex data, which is the way we compare different type of RDTs. These are all brand, completely different from one the other. And you see that many of them have a panel detection score which is above 75%. It doesn't mean that this is the positivity rate at 75%. It is the way calculated in a very elaborate way that on 100 samples of Plasmodium falciparum in the lab, this test has given 75% for positive readings. I don't know if Lina, you can go into the looking at the list of participants and maybe making somebody mute if possible. And the same is done also for the Vivax detecting test. You see in green is those which are here above the 75% detection rate. So we have many tests, bottom line, which can detect very well falciparum and also Vivax malaria. Now, this performance evaluation, which we call it product testing, is one of the three components of the WHO pre-qualification. WHO pre-qualification is now the main basis to select good performing RDTs. And this is often selected by the Global Fund to make decisions, but also from UNICEF, WHO, and other funding agencies. So the pre-qualification looks at a product dossier. They look at the results of the product testing in the lab, the one I presented to you. And they also send some inspectors to the company, manufacturing sites, and they make an evaluation of the quality system which are in place. And based on this, there is a decision and a listing of products on the PQ list. We call it the PQ list. At the moment, there are 22 malaria RDTs which are pre-qualified. They are produced by 8 different companies. And if you go on this and click on this link, then you can get to the page and select and see which one are quality tests. Another way of assessing quality is what we call it lot testing. Lot testing is to analyze in the lab if a certain batch of RDTs, when they are purchased, they also are detecting well parasite at different, it's the same, 200 parasite and 2000 parasites. And this is something that many procurers are doing before shipping the RDTs to the country. So there is also this lot testing procedure. Also, if you are in the field and you start to find some strange, unexpected findings, for instance, a lot of positive RDTs in a place where normally the positivity rate is very low, or you suddenly see that the RDTs, health workers say they don't work anymore. They don't detect malaria, but the microscope is working and they detect parasites. It's possible to take some of these tests in some boxes and send them to the WHO collaborating center in the Philippines, where they are being tested through this procedure. And when they receive the test, after 5 working days, they are able to give the results, and it is free of charge. So it's something to consider if there is any concern from the field that the RDTs may not be working. And when you send it to this lot testing lab, but they also will make in the report some photos in case they see RDTs which are not working well. And these are all examples of very strange findings that certainly show that there is a problem with the RDT. So this will be also available in the report. So now I would like to switch to another quick, let's say, brief video for you. And I hope it's going to work. And it will be on how to do the RDTs. If we were together, we will do this physically on the table between us, but it's not possible. So let me give you 3 minutes of a video before showing you some interpretation of doing an RDT. Let's see again.
Use the loop to put the drop of blood into the sample well marked A. Make sure that the blood is absorbed by the pad at the base of the hole. It should not be deposited on the plastic edges of the well. An easy way to deposit the blood in the correct place is to push the loop vertically into the well until it touches the pad at the base. Push down slightly so that the larger part of its surface touches the pad. Take care that blood does not flick up when pushing the device. Discard the loop in the sharps box immediately. Do not place it on the table or elsewhere before discarding it.
I hope you're able to see it. I go to our next one.
Yes, it was great. The voice is very clear.
Hold the buffer solution bottle vertically and put the exact number of drops specified in the instructions in the buffer well marked B. In this example, we shall use 2 drops. Count the number of drops carefully. It is important to add the exact number of drops.
And now the third one.
Wait for a correct period of time after adding the buffer before reading the test results. In this example, wait for 20 minutes. The health worker added the buffer at 9 o'clock. She will be able to read the results after 20 minutes. She will be able to read the results when it is 20 past 9. While you wait, you can see that the blood is beginning to wick up the strip. It is disappearing from the sample well A and beginning to appear in the rectangular results window. Then the blood also disappears from the results window. It will leave only the control line, and if the test is positive, a line in the test window T. Once the buffer has been added, it is no longer necessary to wear the gloves. Take off the gloves and put them in the non-sharps container. Then wait to read the test results.
Thank you. I'm going back to my PowerPoint slide. Can you see back the PowerPoint now? Can you see the PowerPoint?
Not yet, but it will come.
Okay, I hope. If it's freezing, I don't know. Can you see the PowerPoint or not yet?
Yes, now.
Now
Yes.
good. So there is a latency between us, so that takes some time.
Yes.
So you saw very nicely the video, which was showing us, we put the blood in this well A and the buffer solution in the well B. And this is followed by a migration along the nitrocellulose strip, which is why we call it an immunolateral flow assay. So it's a flow assay, okay? And this is called the test window, and this is the control window. And if there is no line here, the test is negative. Now, let us see, this is a combo test, so it's not as simple as the one you saw in the training video. This type of test, the combo test, will have two lines in the test window. So something interesting for you, because now we're going to have also a little quiz by Lina, always with Slido. And we want to be able to recognize the different type of results. Now, this is a PF-PAN test. And by convention, the first PF is the one which is closer in terms of line to the control line. So when we have one line only in the test window, which is close to the control line, this is a falciparum results. And look at this. Even if the line is very, very, very thin, for malaria test, this is a positive test. This is different from an HIV test. If an HIV RDT has this type of results, the manufacturer will ask to repeat the test. But for malaria, this is a positive test, okay? Now look at this result here. If there is only one test line, and this is very far from the control line, this is the PAN line without the falciparum line. It means that it is a malaria positive, but there is no falciparum. So we call it a non-falciparum results. It could be vivax, ovale, or malariae, or a mixture of one of these three. In many of your countries, you have vivax malaria. So that's the most likely results for you. And here is where a lot of programs have, let's say, difficulty, and a lot of health workers got some mistakes. When you have two lines in the test window, this could be a falciparum infection or a mixed infection, which have a falciparum plus another species, generally is vivax. This is not a mixed infection by default because the PAN line, which is this one, it can also be activated by falciparum parasite. So sometimes falciparum alone can be like this, or sometimes a falciparum result could be like this. And we need to classify this as a falciparum monoinfection or mixed. We cannot make a difference. If it is like this, it definitely is a falciparum infection, no doubt. But sometimes, often because the parasite density is a little bit higher or the antigen load is higher, both lines will be positive also in case of a falciparum monoinfection. So it could be two different type of results. I remember in many countries like Burundi, they started to introduce combo tests, and they have like an epidemic of mixed infection. And this was really not detected before, and simply because many health workers were misclassifying this result as a mixed infection. But it could be either falciparum monoinfection or mixed infection. Now then,
Angela, just to support what was it, we had the same in our countries also. If you go to World Malaria Report, suddenly you see there is increase in mixed infection in some countries. And then the reason was exactly what you mentioned. I mean, we had in Pakistan also, for example. I mean, that we had in Afghanistan, suddenly increased in a huge proportion of mixed infection.
Yeah, thank you.
Dr. Passman, I also add here, it happens also with us in Bosaso, but there was a lot of confusion. Then we send 2 batches, 95 samples with 2 lines to Cambridge and to also Camro 3, and another batch of 45. And all of them tend to be single falciparum positive, not a mixed over.
Yes, yes, very good. Somebody is writing, this is very confusing for the health workers. How can they differentiate between falciparum and mixed infection? Unfortunately, this test cannot make it because it's a PF-PAN. If you have a PF-PV test, which I know some of your countries have, PF-PV is very clear because you will know that it is, if there are two lines, one is for PF and the other one is for PV. Unfortunately, the PV test will be missing some ovale and some malaria, but these are very rare infections and sometimes not, I would say, a major public health risk in missing them. But with this type of test, this is the correct way of recording the results, something to remember. Now, another possible result is invalid. Invalid, there is no control line. And even if you have the two test line or one test line, if there is no control line, the test is invalid. There is something wrong with this test and it needs to be repeated. If I have a result like this falciparum, I have a falciparum. I don't need to confirm anything. I have a very, if I know, if I have a result like this, I can say also, I'm very clear. I know that this is a non-falciparum malaria. It could be Vivax. And I may decide, if I know that in my country I don't have any Plasmodium malaria, maybe this needs Primaquine as well. Could be ACT plus Primaquine. Now, if I have a result like this, and I would like to know if it is really Vivax or a P falciparum and P Vivax infection, then maybe it's good to have a microscopic examination. But this is only if you have a Primaquine to give. If you don't have any Primaquine, what is the point of knowing that this is a mixed infection? You give an ACT. The patient, unfortunately, if it is a Vivax also infection, he may come later with a relapse and you may need to think about maybe this person was a mixed infection, falciparum, Vivax. Maybe at that time you want to go for microscope directly. So I hope this is clear. The microscope itself is not wonderful for mixed infection. It really requires very good skills, and some, I would say many mixed infection under microscopy may be missed and detected only by PCR. So I would say that if you have a doubt and you can, in this case, maybe you need to give Primaquine, you have Primaquine available, then it may be good to check with a microscope and somebody which really can make a diagnosis of mixed infection. It's probably you need to send it to a good lab to make this analysis. I think these are the three types of results: negative, very clear; invalid; and positive. We have different possibilities. It will be a little bit more quick, but you have the presentation with you. And we will look into the diagnostic performance of microscopy and what are the major determinants. Very important instrument and extremely precious, but often is not well done. It's not, there's a lot of complexities and the results are not very reliable. And we will describe some of the resources that we have for quality assurance. And this is a study from Tanzania, which shows major problem with the results. They took slides which were already assessed in the field in routine health facilities, and they did a second reading, and they were 70% false positive. So a lot of what was declared malaria in the health facilities, when you reconfirm by very, let's say, competent microscopist, in this study they found it was not good. But also in the United States of America, so it's not a resource limited country, there is a lot of problems with microscopy. So if you look at here, out of the whole country, all the labs which were reporting at 150, maybe only 33, they use GIMSA. And very few count more than 300 high-power fields or more than 500 red blood cells. And this is really a very low examination of the thin film. It's not at all adequate. And if you look at also those which are giving results within 24 hours is extremely low. Those which are able to report species in the United States of America is very, very low, like 5 out of 149, extremely low. So it's problematic everywhere in malaria endemic countries and in non-malaria endemic countries. And it's important to remember that there is a lot of tests which are done for malaria diagnosis. If we look in the world, in 2016 and 2017, there were more microscopy slides examined than RDT performed. So on the global scale, and some countries like India, they are really very into microscopy instead of RDTs. And microscopy has many issues when it comes to performance. And one is clearly how the lab technician has been selected by the School of Lab Technicians, how he has been trained, how it's been assessed, and all this really enters into the competence. But there is also a lot of issues around like supervision, and are they being checked on a regular basis? What about the quality of the GIMSA, which is sometimes problematic, and even the slides which are available? Do they have the right operating procedures? Do they receive regularly all the supplies in time and they can perform so with quality equipment and quality supplies? And also the work environment. Do they have so many slides to examine per day that is actually not possible to do a proper examination? Now, one slide will require at least 10 minutes to do a very good examination of the thick film and the thin film. And we know that in a busy lab, sometimes it's 1 minute, sometimes even less. So in 1 minute, one can miss a lot of parasites in the blood examination. This is just to tell you we have several good resources, and we have training materials. We have a CD-ROM, and we will have an assignments with the CD-ROM. We have bench aids, which are very good material for the lab technician to keep in the lab. And we have a manual for quality assurance of microscopy. And in this manual, it describes at different levels what needs to be done to have. And in any system, in any country, there needs to be a core group of microscopies which should be assessed and certified using an external competency assessment. And this should be really the core group that we know are normally in the National Reference Lab. They are recognized as the microscopy level 1, or basically experts in malaria diagnosis. We will review a little bit what this implies, because it's a key activity in many of your countries. Now, this manual has a lot of new things and like internal quality control procedures. There is also what countries should do for their own microscope in terms of national competency assessment. A special type of supervision, which we call outreach, training, and supervision, and supportive supervision, OTSS, which is very interesting because the supervisor is also becomes like a coach, and they provide the training while they do the supervision. It's not just to assess that everything is going well or not well, but also to support the microscopy. And also it describes what we call proficiency testing, which is also another way of assessing the quality. So we have many different approaches to improve the quality of the microscopist. One thing which is available and important, because with Dr. Kazem, we are working on the Arabic translation of these documents, is a series of standard operating procedures which are very detailed on each step that the lab technician should know and should really have available and just to refresh. So these are available on a website, the English version, and soon we will be finalizing the Arabic versions as well. One thing that we basically promote as WHO is the external competency assessment of malaria microscopists. So this is a system that we perform, is like an examination of the microscopist. So it's a formal assessment to see competence and to see they can detect if the parasite is present or no parasite seen, what is the species and what is the parasite count. And according to their capacity to detect correctly a certain number of slides, they are put in 4 different levels of competence. So level 1 is really high level, and level 4, basically they need retraining. Basically, major problems have been identified. And the way it works is like they are exposed to a series of slides on different days, and they need to be able to recognize positivity, species, and parasite densities. And these slides are very well characterized by WHO, and they're used in all competency assessment workshop in the world, everywhere. So a microscopist level 1 in Sudan is as good as level 1 microscopy in Thailand or Philippines or India, it doesn't matter. So that's very important in terms of, let's say, assessing the level of competence. They get a certificate if they're level 1 and level 2, and definitely there is a series of tasks that then they are allowed to perform. Now, we reviewed that there's been a lot of experience, more than 200 workshops done in the world. So more than probably 2,000 microscopists, probably more 2,500 microscopy has been assessed over the years. And one big discussion has been, do we need before these workshops to refresh basically do a refresher training? And there was a publication by the Americans. They showed that in many African workshops, when they were doing a refresher training and you evaluate the level of the microscopist, those workshops where you have done a workshop, a refresher training, you clearly see that they have a better level. So their final results are much better. So we took all of the results of all the workshops done so far. We make an analysis and try to see those which did not have a refresher training compared to those which have a refresher training. look at parasite detection, species identification, parasite counting. There is some little improvement if they have done refresher training, but when you do some statistics and analysis, it's not significant. So a lot really depends on the contents of the refresher training. And that's where probably there is a lot of heterogeneity, so a lot of noise, and the results are not always consistent in showing that it's good to do refresher training. And since it is doubling the cost of the external competency assessment, we are still not clear it is a good investment to do. Also, what we did, this was more than 1 year ago, we reviewed all the e-learning tools that we have for malaria microscopists. And 2 of them we reviewed more in detail. One is a CD-ROM, which is available on WHO website. You can download. And the second is a new e-learning course, which is all available on a memory stick. So this is very interesting and is going to be used in Sudan very soon. So very interesting experience, which if it goes all well, which we expect, may be extended to other countries. And very relevant today because again of the limitation in doing face-to-face training. So this is a training course which has been developed by AMREF, Health Africa, with different partners. It has 40 hours of training, and it has inside the course like a virtual microscope. So extremely interesting. It's possible to see a very nice image. This is a vivax parasite. And then to use the arrow keys up and down like you are moving the micrometer of the microscope to put on focus the image. So there are also demonstration videos, and there is a sort of a pre and post test. At the end, if the participants are good, they get a certificate. So the course has a component online, just I think for the registration, but once they are registered and the participants get the memory stick, they can do the course offline, and they can connect at the end to get the final verification and the certification that will require the connection, the connectivity. So very interesting. And as I said, maybe Dr. Kassem, you may like to say a few words about the experience, what is being planned for Sudan, for the other participants to know as well. Just to say that these are the contributors, and not very expensive, very interesting, and very needed now because of, as I said, we need to use more tools and approaches for training which are at distance, at least until the COVID pandemic will be over.